So we're going to explain the inspiration and conceptualization of this new fellowship track. We're going to outline the institutional resources that were needed for support. We'll review the process for approval that we underwent and discuss the formulation of the learning objectives and the design for the rotations that we specifically chose for the perinatal track itself. We'll provide some examples of tools for feedback and discuss challenges of evaluating unconventional rotations. We'll outline our methods of advertising and recruitment and think about future directions and impact on the field. It's really the last three of these objectives that we're hoping to integrate your feedback and get some thoughts that you have on where we are. So first we'll start out with why to establish a fellowship track of this nature and why here at Lurie Children's and Northwestern. We'll go into some of the stakeholders and funding that were explored, as well as cover some of the things that I outlined on the slide before, including the learning objectives, the rotations and experiences, and then thinking about narrative feedback and performance evaluation, recruitment, and future directions. So when we think about why this fellowship track, the first thing that we really talked about as a group was an increase in the number of applicants to our pediatric track for palliative medicine who were already trained in or who had an interest in training in neonatology and expressed really this specific idea of a career at the foothold of an intersection between neonatology, palliative care, and ethics. And we thought to ourselves, how could we certainly create a meaningful fellowship experience for an applicant within pediatrics who wanted to pursue these interests? But also, is there an opportunity for something special and unique that we could pursue that could really outline this training? We also recognize that there is a greater need for perinatal palliative care expertise, and both in part due to advances in perinatal medicine with diagnostics and interventions that are available, as well as the changing access to prenatal medical procedures and care, some of which, within the political landscape here in the States has impacted the way that different delivery hospitals and fetal health centers are able to provide care. So as I mentioned, we started to see an uptick in the number of applicants who were either coming in with a background in neonatology training or who had expressed a specific interest in neonatology and hoped to pursue it, after palliative medicine fellowship. We imagine that when we look at applicants specifically devoted to this perinatal palliative medicine track, we will get both neonatology fellows and pediatric residents who have an interest in pursuing neonatology fellowship or practicing some level of palliative care and perinatal palliative medicine. So as we look to design this fellowship track, we really identified four main goals. One was to develop a unique training opportunity in four perinatal palliative care domains: clinically, educationally, within research, and program development. We wanted to adhere to the standards of pediatric palliative care fellowship training in accordance with ACGME requirements in order for anyone who underwent this fellowship track to be able to sit for boards. We also wanted to improve perinatal palliative care education and exposure for other pediatric subspecialty fellows. So we were thinking of ways of how we could augment the educational curriculum and resources that we would be leveraging for the fellow in this fellowship track that would allow for additional exposure for other subspecialty fellows already at Lurie within areas such as neurology, cardiology, and maternal fetal medicine. And then lastly, we were really seeking to become a national leader within perinatal palliative care education. So why Northwestern, why Lurie Children's, why did it make sense to start this program here? Well, we have a well-established pediatric track within our adult fellowship program, and we'll talk a little bit about kind of what that looks like. We have a large pediatric palliative care division with 5 physicians, 4 advanced practice nurses, and a nurse coordinator. This is in addition to a robust perinatal palliative care service that is also staffed by 2 physicians and a dedicated advanced practice nurse. And we collaborate with a large delivery hospital that has established psychosocial resources, including support within social work and a perinatal bereavement support network. And then lastly, we have collaboration with the Chicago Institute of Fetal Health, which is a large regional fetal health center here in Chicago. So this is just to showcase the members of the perinatal palliative care team. And Natasha Henner, who is not with us this afternoon due to service obligations, and then Jessica Fry, who's here with me now, as well as an APN, Grace Knowles, are our primary providers within this group. So I mentioned that I would talk a little bit about the current landscape of our fellowship training here at Northwestern and Lurie Children's, just to make sure that you have an understanding of what our program currently entails. So right now we have 5 fellows that match to the hospice and palliative medicine program. That includes 3 adult track fellows who are primarily housed at Northwestern. We have 1 pediatric track fellow, and then now we have this new perinatal track fellow. The clinical sites for rotations include the Children's Hospital here at Lurie Children's, the Chicago Institute for Fetal Health, Prentice Women's Hospital, which is our main labor and delivery hospital, Northwestern Memorial Hospital for adult palliative medicine rotations, work with our community hospice partners. We also have our fellow rotate through the Shirley Ryan Ability Lab, which is a long-term care facility for rehab, as well as Almost Home Kids, which is a transitional program for families, for children who are awaiting additional resources to be able to be cared for at home, or for respite for families of children with complex medical needs. Just to give you an overview of kind of who we are and why we could sustain a program here. So Lurie Children's Hospital is a level 1 pediatric trauma center. We have over 350 inpatient beds. Within our main hospital and our outlining satellite clinics, we care for pediatric patients within 70 different subspecialties, and there are over 1,800 physicians who are associated with our network. The most recent stats that we've cared for over 250,000 children each year, and patients have come from places all over the United States as well as internationally. And we are the top children's hospital in Illinois, ranking in all 10 of our pediatric subspecialties. Prentice Women's Hospital is one of the largest NICUs in the country. They have almost 14,000 live births per year. They are also U.S. News and World Report ranked and have a large maternal fetal medicine division and a strong maternal fetal medicine fellowship program. The Chicago Institute for Fetal Health provides pre-birth counseling and care, as well as corrective fetal intervention, and has a renowned surgeon under their umbrella. They have a multidisciplinary team that makes up their center, and they do over 1,800 consultations each year for a variety of fetal disorders. So those main hospitals, as well as the following programs here on this slide, were really the stakeholders as we sought to explore what it would take to establish this fellowship track. So that included kind of our local hospital GME program, as well as specific services within the Children's Hospital, including palliative care, neonatology, cardiology, and neurology. We also sought the input from the Chicago Institute of Fetal Health and their fetal surgery program, and then our adult partners at Northwestern and Prentice Women's Hospital, both within the palliative care divisions and for maternal fetal medicine. In order for us to present this as a sustainable model, we had to secure some funding, and we did so through a grant that was received and with philanthropic funding from the Lord Foundation. With that initial support combined with a local philanthropic gift from a family that was willing to support educational activities for the fellowship, the hospital at Lurie Children's was then able to commit to fund the remaining salary support to sustain this position for a fellow. So once we had stakeholders in place and the funding approved, we presented to the Department of Pediatrics here at Lurie Children's and took our proposal to our local GME at Northwestern. Once both were signed off as approved, we were able to approach ACGME, who came through and granted the approval for this novel fellowship track under the adult medicine program at Northwestern. So once we had approval, we really had to get to the nuts and bolts of determining what our learning objectives would be. And so in order to do that, we had monthly meetings with the Perinatal Palliative Care Fellowship leadership, which included myself, Jessica Fry, and Natasha Henner, who has now been able to join our call. We also included members from a variety of the other disciplines that were part of kind of the stakeholder team here at Lurie Children's, as well as our colleagues at on the adult team at Northwestern. We had 1 to 2 meetings with each stakeholder to establish overarching goals and objectives for the rotation, and then identify who would be the direct supervisors for each rotation. We followed that up with a variety of ad hoc meetings with secondary stakeholders to fine-tune the goals and objectives for each rotation, and then start to break down the schedule for the fellowship. This is just an example of some of the learning objectives that we outlined for one specific rotation. This is from neonatal neurology. This will be a 2-week rotation within the Perinatal Palliative Medicine Fellowship. And this is just to give you kind of an example of what we derived as we met with each group in thinking about the specific rotations that we would want for the fellow. We outlined the fellowship structure to include 4 months of time spent with the pediatric palliative care team and their inpatient consult service. The fellow will also spend 1 month on the adult palliative care inpatient consult service at Northwestern, and then 3 months with our community hospice partners. Those are already established rotations that our pediatric fellow completes, as well as our adult track fellows. And then in addition to that, we broke down 4 months of perinatal palliative care rotations. This is a screenshot from a portion of our mock schedule for our perinatal palliative medicine fellow. You can see that it includes a variety of rotations, including time spent in the Chicago Institute for Fetal Health doing prenatal consultations that include genetic counseling. We also have time spent with our cardiology colleagues focusing on experiences within our cardiac ICU, time spent in the single ventricle clinic, as well as time spent with our heart failure and transplant team. Our fellow will also rotate with our MFM colleagues at Prentice Women's Hospital. They will spend time in family planning, labor and delivery, fetal echo and ultrasound, more times with the genetics team, as well as some time spent with the obstetrics infectious disease program. And they will also rotate through the NICU and spend time with our BPD program, our NICU psychologist, and some of our interdisciplinary colleagues within child life and PTOT and speech therapy. And then neonatal neurology is also included, and I had shown you a brief excerpt of some of the learning objectives from that rotation. We had an opportunity to pilot some of these rotations with our pediatric fellow during our last academic year. These included experiences with the Fetal Health Center, where the fellow attended multidisciplinary conferences, planning meetings, and fetal procedures. They observed fetal echo and radiology sessions, as well as spent time with genetic counseling. And they observed the work of the nurse coordinators and social workers within the Fetal Health Center to see how, as an interdisciplinary team, we're providing care for the consultations that come through. The other rotation that we were able to pilot was with our maternal fetal medicine program. And so the fellow attended MFM, family planning, and OB/GYN clinics. They also participated in labor and delivery and antepartum rounds and observed high-risk OB consultations. They also attended perinatal death review and the M&M conferences. And so we were able to garner feedback both from the supervisors on these rotations as well as the fellow who piloted them about the structure and timing, and we fine-tuned the schedule for the perinatal palliative fellowship track. We anticipate that our perinatal palliative fellow will have a couple different opportunities for longitudinal patient experiences This will mean being able to follow a patient and family from the initial consultation in the fetal health center to perhaps an admission following the birth of a baby with single ventricle to our cardiac ICU, and then follow up to our single ventricle clinic. We see opportunities in a variety of outpatient settings, not only the single ventricle clinic, but also NICU follow clinic, as well as neurology outpatient clinic for babies that may be born during the time that this individual is in fellowship. We also wanted to just highlight a couple of the fellowship education opportunities that we designed and have intertwined into this fellowship track. This includes some already established fellowship education, including our Monday Regional Fellows Conference, which it is a conference that includes simulations and didactics for fellows from across the Chicagoland area, not just here at Northwestern or Lurie Children's, but other Chicago institutions. We also have a conference series that is a weekly education conference between staff at Lurie Children's and Northwestern that the fellows participate in through journal clubs and case conferences. We have a supportive oncology curriculum that occurs weekly for the palliative care and oncology fellows here. We have education conferences that are specific to our pediatric team at Lurie Children's. And then we have a longitudinal spirituality curriculum, which is unique to the fellowship program at Northwestern, which includes immersive experiences and field trips to faith communities in the Chicagoland area, as well as some didactic lectures. And all of our fellows do participate in Palliative. We wanted to enhance that educational exposure by providing some perinatal education, and I'll let Jess Fry talk specifically about some of these opportunities in more detail.
So many of the opportunities that you'll see on this screen, and I'll run through them quickly, so hopefully we can get to some discussion at the end, were things that we already had in place. They weren't necessarily dedicated for palliative care trainees, but we're adapting them for palliative or for perinatal education. So in particular, for the last several years, we have run a series of simulation training events, both an annual communication simulation is focused on perinatal care, as well as monthly for our neonatal fellows, flash communication simulations. And we hope to expand upon that with specific dedicated perinatal counseling simulation as well. We have an existing perinatal didactic lecture series that we have created to be able to facilitate the education of pediatric track fellows that are coming through. And then the rest of sort of the various kind of conferences and grand round opportunities and lectures, the Montgomery lectures are an ethics-based system that's run through the Northwestern system. All of these are formally existing, but bringing them together in one place to focus on that perinatal education. Another piece that was really important to us from the beginning of the development of this track was that we are providing education not only to a specific trainee, but also more broadly as well. So we have conceptualized what we hope to become quarterly seminar series that we are calling Perinatal Palliative Care from Innovation to Practice, and are working on inviting local and regional experts on a variety of topics related to that intersection of palliative care, neonatology, and ethics. And you'll see examples of the topics that we've been thinking through. We have specific speakers in mind for all of these.
And so then two of the areas where we're hoping to get some of your feedback. One is we have a proposed kind of narrative feedback form that we will be distributing to the supervisors for the rotations that the perinatal fellow will be joining, as well as a similar feedback form for the perinatal fellow to be able to talk about their rotation experience in a more narrative dialogue, as opposed to checkboxing milestones, which is the typical way that we measure a experience on rotations for our current fellows. So recognizing that some of these rotations will be largely observation based, we're hoping that this narrative feedback form provides a little bit greater detail about the experience for the fellow. But this is an area that we're still trying to troubleshoot and think about as what is the best way to evaluate these rotations and think about feedback. Another area where we are hoping to get some input from you all is recruitment. So we have advertised in a number of places, including the Palliative Care Listserv, AHPM Connect, at PAS, and then on the website for neonatal training program directors. But there may be opportunities that we haven't thought about where folks would be interested in learning about this fellowship track. And so if you have thoughts about where else we might think about recruitment, that could be helpful. And then, as we are thinking forward, we imagine that there are opportunities for this individual to pursue a career within a pediatric palliative care program at a large academic center, or even potentially in a community where they're associated with a large delivery hospital, or another hospital system with a fetal health program. But how do we recognize whether or not we're, having an impact on the field and measuring the success of this fellowship? And this is the last area we're hoping to get some input from all of you. Certainly we think employment opportunities may be a marker of success, academic productivity, thinking about, becoming a national model for how to create these fellowship tracks in other places. Looking at publication of the curriculum, but certainly we're open to other ideas that you all may have. And then lastly, we think about the future direction, like I said, being potentially a model for other subspecialty tracks, maybe not just perinatal palliative care, but other subspecialties within pediatrics. And then thinking about how to publish and really put this program development out there for others to utilize. So we'll stop there and then hopefully be able to get some input from all of you about what you think, we may be missing or how we might add to this.
Thank you so much for that really interesting presentation. And we have about 4.5 minutes for discussion. And then, as I said, I'll kind of manually move you guys as the speaker over to the other room, and I'll move Erin over to this room. So the floor is open.
Hi, I'm Margot Hoover-Regan. I'm in PT Monk and Peds Palliative Care at UW-Madison, so not far away. And I trained at Lurie, but it wasn't called Lurie then. So I had the opportunity to mentor a colleague from her assistant to associate professor promotion for neonatology, and she also has did a lot in terms of perinatal palliative care. So even though it wouldn't, my background wouldn't suggest it, this was really is something that I've kind of picked through a little bit. I don't know, in terms of like getting the word out, it sounds like all the things you're doing are good ones. I mean, those are good, like national platforms or groups to put this in. But even just thinking like regionally, being in the same region as you, maybe even offering to be like a speaker. Or I'm assuming at Northwestern, they have some kind of outreach in terms of educational outreach programs, but just talking at other institutions, presenting on some kind of perinatal palliative care topic, and then including some information about your fellowship might be helpful. And remind me, I'm sorry, you both introduced yourself, but are either of you program directors for neonatology?
Neither for neonatology. We have a strong working relationship with Patrick Myers, who is the program director for neonatology here at Lurie.
Okay, yeah, then I would just, you probably already did that, but I just thought also to kind of try to get into that world a little bit too.
We do see a question in the chat about exposure to bereavement services and clinical ethics. And yes, part of the perinatal track, both kind of the pediatric track and the perinatal track will include work with the hospital-wide bereavement services within our children's hospital. The perinatal track will also work with the perinatal bereavement specialists. There's a social work team that's been long established at our delivery hospital, and they will work there. We do have a vibrant Lurie ethics program. My multifaceted work is perinatal palliative care and neonatology, and as a clinical ethics consultant here at Lurie. So there are definitely ways to connect with the Lurie ethics program, both educationally and potentially thinking through observing consultations and things like that if the fellow would express an interest. But we don't have a formal rotation with the ethics program as such.
Sorry, just to go back, the other thing that I meant to say but forgot was in regard to your question about how to kind of disseminate your experience and your information. And again, these may be things you're aware of already, but I've had some experience with that, like with MedEd portal is a good place for educational initiatives. And I think I'm not real familiar with this, but remember this from some of the committee meetings for my mentee, that they're, like a GME type journals, I think, are another good place to showcase, this kind of a really unique fellowship program.
Yeah, actually, on the subject of dissemination, you can email the associate editor, but Academic Pediatrics has a view from the APPD, so you could email, I think Michael Pitt is the associate editor, so you could email to see if that would be something that might be of interest to them.
Thank you.
I know we're running out of time here. I'm just curious, the little survey that you had given about each rotation, it looks like that was for every rotation, like all of the perinatal rotations they would end up doing. I just worry if you're going to have like drop off of how well that survey gets filled out as the year goes on because of the length and if they get it after every single rotation. So if you're thinking, is the survey intended to improve this rotation for next year, or is this survey intended to show at the end of the year that I had good, exposures? And I wonder if a different survey if you need different surveys for different purposes there. So just have some clarity around what you're actually trying to measure with that.
Thank you for that thought. I think that is an area where we have struggled a bit because we do worry about fatigue in terms of constant need for evaluation, but also recognize that we do need some way to mark the experiences that this individual has had, as well as try and understand what could be improved. So thank you for that feedback.
Okay, so it's time to switch rooms. Thank you so much for the presentation and for being willing to try out this new format. So sorry, I have multiple things popping up on my screen. Okay, so Teresa and Jessica, I'll move you to room 1, and I'll move Erin to this room 2, and just hang tight, everybody. Okay, Erin, you made it. Okay.
Great to see you all. Thanks for being here. I got a lot of good feedback. My presentation is sort of in 2 parts. Hi, Lauren. Oh, it's good to see you. I got a lot of great feedback for Hi, Hadley, for the first piece of my question. So I am actually going to give you a overview of the project, and I'm going to skip a lot of slides and go to the second piece so that I can really focus on that part of the feedback. So grateful for your flexibility. Let me just share my screen and get y'all where I could see you and do some things. All right. Forgive me, I didn't reset the presentation. In 1 second. Okay. So you all work with not only grieving patients and families, but hopefully, I imagine you have a lot of experience with trainees who need as much help sometimes. I've noticed in my time here that I have really, I've had the opportunity to talk with residents both in a formal and informal way about how we can better help them care for grieving patients and families. And so I will let you, I will bring you up to speed with pieces of my grief training curriculum that I'm hoping to implement. But first, just a bit of background. None of this is new to you, right? Grief is a humbly broad, yet, are you guys seeing the slides or the presenter mode?
Slides.
Slides. Okay, cool. Just wanted to make sure. My notes are great, but like there's a lot of like just like stuff in there. So grief is a humbly broad yet intimately personal concept, right? It's much like palliative care. There's a lot of ways that grief manifests. Y'all might resonate with one or more of these right now, and I promise your trainings do too. In particular, when they lose a patient, there are several levels of losses that they might experience, right? It might be the relationship with the patient. It might be that they identify so much with the experience of that patient. That patient might have caused them to challenge assumptions that they had about what life or what living is. And of course, when we grapple with the professional expectations that are set upon us in medicine, right, to cure and fix and make whole again, what happens to a trainee emotionally and mentally when they cannot meet those expectations? And so, again, through my conversations with residents, I've learned that at least here, they don't necessarily feel prepared to address the grief of patients and their families, and they have few structured spaces to process it. And so, from the literature, these are a few pertinent related highlights that I have for you that hopefully aren't news, but grieving patients can be negatively impacted by either avoidant provider behavior or lack of advocacy. And resident and experience is a prominent reason for feeling guilt after a patient death. As we all know, emotional debriefings is my love language. That increases or decreases the risk for burnout. And now, finally, as of like February 2023, the ACGME has formally recognized both grief and bereavement in several of their PEDS residency competency domains. So there are really lots of opportunities that we have to advance existing grief curricula. And now I would hope and sort of expect that they would be supported by residency programs, but we'll see. My learning objectives sort of going into the needs assessment that I developed for residents to sort of figure out what they need are fourfold. I wanted to measure their experience with grief, figure out how it affected them as a human, how comfortable they are in communicating in these situations, and are they knowledgeable of the services that exist to help them with their grief. And I promise I have a lot of results specific to each learning objectives. I am really just highlighting a few pertinent ones for you right now. The manuscript will include it all, I promise. It's coming in like 2024, hopefully. But to summarize, the clinical experience that a resident goes through increases significantly throughout residency. So this is what this Spearman correlation is saying. There is a positive correlation with clinical experience and year in residency, right? And so it's quite significantly increases as a resident moves on in training. Conversely, formal training in grief and comfort and competence with conversations about grief do not get better with just being in residency longer. And so this argues that you need some sort of, at least at this institution, we need some sort of curriculum to help advance and close these gaps. And then I think sometimes that what residents say to us, we can't underestimate the value of these quotes, verbatim quotes. They're really looking for this. So there not only is a need as far as data goes, but from what they're saying to us directly. And I think this last point really hits home for me. Okay. So in conclusion, I sort of approached a couple of these already. Residents are increasingly exposed to grief. Despite that, there's no significant difference in their formal training opportunities and comfort. They, of course, would benefit with more practice from getting the words out with a lot of the conversations that we are more comfortable in, and that routine structured debriefing sessions can really help with the impact that grief has on their ability to provide patient care and learn. And I don't need to emphasize anymore that a curriculum could be helpful. Okay, bear with me as I get to the point in my curriculum that I want to ask you about. Okay. So as part of my curriculum, I am hoping to implement communication skills simulations. And currently, what exists at WashU is like one single communication sim on delivering bad news one time as a senior resident. Maybe, right? This is offered to like 2 elective rotations. And so we capture not even every senior in this curriculum. And so my first effort really is structuring sort of within key rotations, sort of high yield, high risk rotations for having conversations that relate to grief, simulation sessions embedded into these rotations. And so neurology, we'd be thinking about how to approach a conversation about uncertain prognosis. For hospital medicine, for example, how to approach conflict with a patient's caregiver. Of course, on key rotations, our rotation actually packed are the residents on our elective and some other electives. We'd approach death and dying. And then medical error would be the fourth sort of brief topic that I'm hoping to get every resident to do a sim on at least once in their residency. It's a really large ask. There's a lot of key players that go into this. It's not just the research team, which I'm grateful to have buy-in from junior faculty that represent a lot of those units and rotations, right, where residents are going to find themselves in these situations. Thankfully, I've gotten a commitment from 4 rotations for monthly protected time. Unfortunately, I'm still waiting to see if there's funding for standardized patients, but at least the residency is supporting it. And I do have some protected time right now through my fellowship. And within these communication skill sessions, it's structured as a sort of fishbowl style, right? With one faculty facilitator, one standardized patient, and then a group of residents. And they could be interns, they could be a combination of interns and seniors, and we basically put them through these sims after a short didactic. The barriers here, most pertinently is time, right? Like I don't have time to, or offer, from the programs or the rotations to do a full like didactic, right? Where we go through all the idiosyncrasies of delivering bad news or medical error, right? And then a significantly long debrief at the end of it. I really do have to focus on the sim itself, which is why my questions to you and what I really want to think about today is how do I assess a pediatric resident's ability to do this and to display comfort and competence, right? But also prevent decay. Because I think the biggest piece that I'm hoping to accomplish with this sim curriculum is that their recall is much quicker, right? These skills and strategies and words decay less over time because they're doing it more. And so I'm actually just going to get to that slide. So the evaluation feedback piece, the pilot year that is approaching for us, if we do get funding, really will be focused on measuring the feasibility and acceptability of these sim sessions. Again, the needs assessment data suggests that they want these, they need these, they're not getting the time or the opportunity, right, to say these words on their clinical rotations. And so they do sort of need these sim sessions to supplement that. And then, of course, some qualitative data, right? I really do want to know, like, in the months that follow up each sim session, how did you apply these skills? And then I'd also like they're also going to get feedback, right, from the SP, from the faculty, right, that are sitting there and evaluating them and sort of facilitating the encounter. And specifically, I've developed a rubric or sort of a checklist for each grief encounter that I'm going to work through with you right now. So as I think about communication skills that residents should be able to accomplish in a simulated or real life clinical setting, I think about basic communication tasks and the relevant communication skills, right, that they learn sort of in their med school and residency curriculum, and then communication skills that are specific to a grief encounter. And again, the 4 ones that I'm thinking about are the dying patient, medical error, conflict mediation, and talking about uncertain prognosis. And I developed these based off a pre-existing sort of communication skills toolbox that exists for our medical schools, very in-depth communication skills curriculum. And, we've just learned over time, right, that the dying patient, right, you can see that there's like remap in here if you look really close. There's a lot about empathy and taking perspective and acknowledging uncertainty. And so while these skills aren't new to us, I thought that it would be best to organize them based on the encounter that I'm trying to assess. And so all to say, what I've developed is a sort of checkbox, an evaluation sheet for each sim that starts with 2 open-ended questions. One area of strength, one area for growth, and then checkboxes next to each identified skill, whether it's one of those basic communication skills or whether it's one of the specific communication skills that's used for the grief sim of a dying patient. And the goal would be for the faculty, as the resident is going through the encounter, to be watching for and looking for these skills used, and providing a checkbox, like if you did it, you get a check, and if you didn't, there is some additional space below that for any feedback or observations. And of course, there would be verbal feedback that'd be given to each resident after each encounter. But I developed this sort of in the past couple of weeks with input from the team of faculty that I have. But I'm really curious, to you all, if you have expertise in assessments for SIM, or if you have done something like this, or just have any advice, feedback, or guidance for how to best implement this in a way that can gather good data and provide residents with a concrete sheet, right, to walk out of there with, right? That's sort of what I was thinking, is that they would walk out of there with, some evidence of like what I did well, what I didn't, and could enhance their recall the next time they get to one of these sim sessions. So I'm going to pause there. I feel like that was a whirlwind, and so I'm really open to your questions. I'm happy to clarify things, and then talk a little bit more about SIM assessment. I'm all ears, so please unmute and join the conversation.
Erin, this is great. It's really nice to hear about this project. I'm wondering, I might have missed this, but the faculty who are also observing the SIM, is it just you, or there's other palliative faculty who are the ones giving this feedback or rating them? Can you say a little bit more about what their background is?
Thanks, Lauren. So I developed a team of faculty. I sort of specifically reached out to those who are in these like high risk rotations, right? So I'm working with faculty from the NICU, from the PICU, from the oncology floor, and from the CI. And we really do, and from hospital medicine, actually, because one of my biggest things is that like grief doesn't discriminate, right? Like residents on all rotations need to know that this is something they're going to be able to see and handle. And it doesn't always look like a dying patient. And so that's why I thought having input from people who actually aren't in pediatric palliative care to sort of say, here's what we see, here's how we handle it. Let's create a case that feels natural as it could possibly be in a SIM, to the neurology rotation, to hospital medicine. And yes, of course, like to like the dying patient on the oncology floor. And so I really did specifically, I guess, create my village with that piece in mind, is that, yes, I have the sort of specialty palliative care experience, and I wanted to really engage and sort of hear the perspectives of other specialties. But they have given a lot of really good feedback about, and the case development that they've helped really deliver has been just embedded in what they know and what they've really experienced with residents on the floors on those rotations. So I hope it's effective at making it feel like a legitimate experience for them.
That's great. I think my question around that is just that, like, I think it's really helpful, even more so than to have it broken down like you do into such concrete tasks when the other people on the team don't necessarily have the palliative medicine training.
That's fair.
Like you have. So that's awesome.
Cool. Thank you. Naomi, I saw your hand.
Yeah, so thank you so much for sharing this. It's super interesting. I have questions kind of about benchmarking where your residents should be for these specific tasks. And also it escapes me what this is called, but actually the process of prior to evaluating or prior to assessing the resident's performance, kind of sitting down as a group of faculty and actually coming to a common understanding of like, what does it concretely look like to this group when a resident has actually explored parent understanding of a situation,
Yeah.
because you will find that, you know, definitely amongst people from different teams, but maybe even amongst like your own palliative care team, the satisfaction that someone has adequately explored this may differ between you. So it's important to kind of come to a common understanding. But then also, I'm not sure that the ACGME has very good benchmarks about like where are the residents actually supposed to be with regards to having checked all of these things off. Is it, and what are you, I guess we can use the new language of CBME with entrustability, but like, you know, is the expectation that after going through all of this training, that you will be able to entrust the residents with all of these specific tasks? Or is the expectation that they'll be, you know, guided through them or something like that?
Yeah, thank you so much, Naomi. I think, you know, the trade-off with making, because I see it in my mind like sort of like a 1, 2, 3, and like, you know, some sort of concrete like narrative about like what is the first level, you know, for assessing experience, what is level number 2, and then what is level number 3, like and I wonder if the trade-off here is just because they're going to have to be filling this out like as the encounter is going. And so I'm asking a lot of the faculty like during this experience, right? Because like Vital Talk style, right? They're going to be writing down everything everybody's saying and then remembering what they said, checking off the box if they did it, and then also providing feedback. And so thank you. It's not that I wasn't thinking about that, but I was just thinking about everything I was asking them to do in a 10-minute encounter. But I agree with you. It's worth sitting down and saying like, here are the types of examples of what expressing empathy might look like, or gathering a perspective. So thanks for that. I appreciate that. Paul, I saw your hand.
Yeah, thank you. This sounds lovely. Along the lines of the fact that people are going to be like furiously rating. One thing to consider is if you want to ask, instead of checking the box responding to emotion, having the person giving the grading a example of showing emotion along with that to sort of remind them when they get their feedback. Oh yeah, I did say that. I don't know what sort of verbal feedback you're planning on, but even I don't know if it is the faculty or asking students to pay attention to this, but actually writing down the headline that they said would be a really helpful piece of feedback to get, because they could look back and say like, oh, I did use a lot of words, but that's hard to write down right as they're doing it. And my only other thought is, I know you had said that you are limited in the amount of time that you have in terms of actually, doing some didactics about this, but there is a risk to giving feedback on a rubric that the learner doesn't understand.
Yeah.
And so never been instructed on what a headline is and a warning shot is, and it's really hard to then say, hey, you didn't do this thing I didn't tell you you need to do.
Mm-hmm. Yes.
And so even if that's like a flipped classroom, just like, here's the expectations for this thing we're about to do, if you want to read about it a little bit, or here's some examples that we're going to look for. But I think it's defeating to go into one of these things feeling anxious about talking in front of somebody and not doing something you didn't know you were expected to do. But I'm sure you thought about that.
No, and thank you for, it's something I've been thinking about, and thank you for bringing it up. I appreciate your idea of the flipped classroom and sort of sending out the data, sending out the paper, sending out the rubric, sending out just like a hit list, right? For, what are we looking for in this, sim versus this sim. And I think that's something to consider, because it will save time. And because the meaningful piece is like getting them in there and saying the words. So thank you for that. Much appreciated. Noam, I saw your hand, and then Hadley.
Yeah, and so Erin, I think this is fantastic what you're doing, and something that I wish we were doing here. One thought is, are all the evaluators going to be physicians? Because as great as physicians are, we're not always the most in tune with all the delicate communication and psychosocial needs. And if there are more allied health people that you could rope in of more with more of a psychological or psychosocial background, that might be really helpful. And this might be a bigger ask, but another thing that could be really helpful, especially for the SIMs involving dying patients. In my fellowship, we did simulations with bereaved parents as the standardized patients. And that was really impactful, getting feedback from a bereaved parent. Right now, I'm part of we're doing a study here with the PICU and ED fellows, having some of these simulations and then having their performance graded by bereaved parents. So that's not an easy thing to scale, but kind of once you get dedicated volunteers, it may actually help with longevity.
Yeah, thank you. No, I that's been like a goal, I think, of our entire team, is how do we build, a resource, right, around, many of the bereaved parents that we know that might find meaning in coming back and being teachers, right, being facilitators, being tools for residents. And I think we just need time to like focus on that. But we've absolutely thought about that. And I think the closest we've gotten to it is just sort of like a panel, like a yearly panel for residents, that not only involve bereaved parents, but parents who might have experienced another type of grief, right? Is it a parent of a child with medically complex needs? Is it an adolescent who went through, cancer treatment, right? Is it an organ transplant recipient? Or some other examples like that. But I agree, a personal exposure to these people, there's nothing like it. So it's on the docket. Thank you so much for bringing that up. Yeah, Hadley.
Erin, this is so awesome. What a cool curriculum that you're creating, and also tying these to some of the competencies and like really having this framework and rubric. I just wanted to add, and maybe not exactly what you're looking for feedback for, but hearing about your thoughts of wanting to not prevent decay and like assess the utility of these skills. I wanted to ask, are you thinking of doing any post survey? And also mention that I've recently learned about the like commitment to change approach, and that you could consider asking them residents after if they plan to change their practice based on what they've learned, and then kind of like look in a later time point to see if they did use these skills to show the impact of the curriculum that you've designed.
Yes, thanks, Hadley. We've been thinking about that a lot. It's something that we can fairly easily implement sort of as this, even in this pilot year, right? So we're hoping to create immediate, like sort of post-SIM surveys of feasibility, right? Did you like it? Did it work? Did we accomplish the objectives? Was this a waste of time? Was this valuable? We reframe it like that. And then my hope is like in the 2, 4, and 6 months post the SIM, sending out just a 1 or 2 question survey is, did you use these skills in another encounter and how? And so very easy, very simple, just to the residents, right? Because you can easily keep track of who actually was engaged in the SIM. And then over time, hopefully get some useful information like you're saying. So thank you for bringing that up. I think that's going to be a really important piece, not only to sort of inform future iterations of this, but to gather more data and support for future funding, grant proposals, et cetera. So thank you very much. Much appreciated. Thank you. What else, team? I'm all ears. This is really good feedback. Cool. Well,
I'm not sure, Erin, I'm not sure if this is actually too much for the faculty to do, but one thing that I think it was at AHPM that I learned this in a workshop was, in addition to kind of one area for growth, but is actually like a concrete recommendation for what they can do to actually grow in that area.
Got it.
And that has transformed my practice of narrative feedback.
Plus concrete.
Yeah. Oh, that is the timer. Wow. Okay, we tried out a new format, and you had a blitz of giving this talk 2 times. Thank you so much, Erin, and also to Teresa, and Sorry, I'm not very good at multitasking multiple things. So I put a link in the chat to an evaluation form. Hopefully it works for people and that you're not blocked out of Google Forms. Your feedback is really important to us, but also to provide feedback for our speakers if they ever want to kind of keep this for promotion and all of that stuff. But for all of those wonderful reasons, we would really appreciate just taking just a few minutes to send that feedback. The link is in the chat. Otherwise, yeah, thank you so much for everyone, to everyone for coming today and trying this new format. Hey, I should put in the feedback form. What did you think of this different format? I'll find out from you how it worked for you, Erin, and
Sure.
I'll check with Jessica and Teresa as well. Okay, we'll have a wonderful afternoon, everyone. Thank you so much, and we'll see you in 2 months.
Thanks all.
Bye.
Take care.